I'm one of the local podiatrists. I'm based in Enniskillen. I work for both the NHS and privately. And I want to talk to you about heel pain. There are lots of statistics available to give you a bit an idea, but to give you an idea of the extent of the problem. In a recent audit of my own work, approximately 3 out of 16 patients came in, found that that was the condition that they were presenting with. So it's approximately 20% on maybe a bad day of my caseload. A study has shown that plantar fasciitis is thought to account for 11 to 15% of all adults presenting with foot pain. And it has been reported as being one of the most common foot conditions, accounting for 1 million visits to physicians in the US. There, in actual fact, apparently studies have shown that it could be more like 2 million visits per year, because most people will present not only to their physician but also to practitioners like ourselves, whether it be physios, podiatrists, whatever. So, and the plantar fasciitis itself accounts for 80% of heel pain and is most common in patients of 40 to 60 years of age. Research has shown that it's most common in runners and those that are overweight. So I'd like you to meet Bill. Now, Bill is a runner and he's also overweight. Now, I'm not saying that every patient that presents with plantar fasciitis has to be both a runner and overweight. What I wanted to show was just a combination, that patients with can be, as I said, can be runners and will present with very severe symptoms on occasion. And even you will have classically our 50-year-old patient comes in, lady or gent, who's just started to run, maybe to do a C2K, couch to 5K, and they've found that into a short time into their training, from being very sedentary initially, they have proceeded then to develop foot pain and had to stop their training, so they've been unable to proceed. Now this leads me on to an American podiatric surgeon, Dr. Russell Volp. Maybe I haven't pronounced his name correctly, has suggested that there's, in actual fact, within plantar fasciitis, there's actually two conditions, and it should be more aptly named plantar fasciopathy, just as Achilles tendinosis is Achilles tendinopathy and tendinosis and tendinitis. So there's been consideration given that there's actually two conditions. So the plantar fasciitis does in actual fact have the inflammation present. So this is an ultrasound scan, and I've put up the query there with regard to inflammation or degeneration. And that's the whole discussion, as I said, around the plantar fasciosis or the plantar fasciitis. And obviously, that's the crux of my whole talk, or the research that I've done. The ultrasound scan shows the fusiform thickening that occurs in plantar fasciitis, and it's said that people with plantar fasciitis are 100 times more likely to have an abnormally thickened plantar fascia. The reports that we'll get back from a radiologist whenever we order an ultrasound scan will specify that they have hyperocheic fascia, and this is present in 73% of the group with plantar fasciitis. It basically shows that, and hypocheic basically means it's lighter than normal. So I want to just speak a wee bit about the pathology of plantar fasciitis, in that a study by Lamont found that there was, histologically, he looked at 50 patients and there was absolutely no signs of inflammation at all, and that's why he appropriately named it plantar fasciosis. So that is basically why a lot of the treatments, patients will come in and they'll ask for a steroid injection. They say it is a quick fix, and for that reason they want to get an injection so that it basically sort them out and send them home. So patients will usually present, the diagnosis is usually clinical, where they'll present with pain and stiffness along the medial border of the foot, with discomfort being elicited on palpation of the medial aspect of the calcaneal tubercle. Patients will present with, often complain of early morning pain and on getting up from rest, with a gradual reduction in symptoms as the days go on, and then possibly returning towards the end of the day. Back to this. This is my the take-home message. We wanted to just tell our patients that 80% of plantar fasciitis will resolve with normal conservative treatments, whether it be stretching, both plantar fascia stretching or calf stretches, taping, all the different conservative treatments. I mean, I've had a number of typical scenarios where people come in and they, like for example, I had a local gentleman in there recently, he was an obese 50-year-old lorry driver. He said he'd had heel pain for over a year. He'd been given exercise to do. He did them for a while. They didn't work. So what can you do for me? And, apart from speaking to them and explaining that they need to comply with their exercises and comply with the orthotic therapy they were given and conservative treatments, that they really just need compliance was the issue more so than the actual treatments that have been given. Next thing then was just a wee bit about the evidence. Crawford and Thompson did a Cochrane review where they reviewed 26 different modalities of treatment in 2003, but that has since been withdrawn as is considered out of date. Since then, there have been a number of very good quality RCTs carried out that have looked at taping, shockwave, stretching and so forth. But basically the treatment despite this myriad of treatments, there's no consensus on which is the best type of treatment. The guidelines even will, the guidelines sometimes don't agree either. There's different groups of guidelines and they don't always, there's no consensus really on who should treat the patient and in what treatment and what's the best treatment, so either. So basically I wanted to talk to you what's new. In my quest for a quick fix for a treatment I wanted to have a look at some other injectable treatments, and that's when I came across Botox or PRP. I was conscious that patients, as I said, wanted a quick fix, and in our neck of the woods, we've been discouraged from doing steroid injections and plantar fasciitis, and so that's why I wanted to have a look to see what else is available. Now, these are both very new, obviously, but I do know that Botox has been widely used for treating spasticity in patients with hemiplegia and cerebral palsy, and it's thought to have a number of actions. It's a neurotoxin which acts by blocking the release of ACH at the neuromuscular junctions. It's also thought to act as an analgesic, and it is shown to reduce muscle volume, which will in turn reduce the size of the intrinsic muscles, causing a relief of pressure on the neurovascular structures trapped under a tight and enlarged plantar fascia. Now, there's been a number of, I did a systematic review and looked at all the high quality evidence, the RCTs, and there really aren't that many available, but what it was shown was that there was a strong correlation between the pain scale and plantar fasciitis, and that the plantar fascia did actually reduce with treatment when it was injected either into the gastrosoleus complex or else into the heel. Just leave it there. So basically the mode of action, we know that the steroid acts as an anti-inflammatory. The Botox I've just explained there. The PRP, platelet-rich plasma, is a bioactive component of whole blood with concentrations of platelets above the baseline values. And it's basically got growth factors which play a key role in the normal injury repair cycle of the body, and it has been used by a lot of sports injury clinics, both in physio, and the orthopaedic surgeons are starting to use it in some places around the region. So this was what I was, in my systematic review, I was hoping to try and differentiate. Now, unfortunately, there were no RCTs that would have looked specifically at a comparison with PRP, Botox and steroid. Most of them just either compared Botox and saline, or Botox and steroid and so forth. But those were the findings. The findings were that with Botox and PRP, that the long-term the effects were more long-term compared with steroid, and that had only very short-term effects. Whereas with the adverse effects were the potential fascial rupture, which is why we were discouraged to use the steroids, and obviously the Botox is a neurotoxin. So now the PRP, we have seen being used with Achilles tendonitis in our trust in the West, and I know it has been used up in other parts of the province as well, and it's just something that to me I feel is a developmental thing that maybe might be coming in the future. that's basically just what I wanted to say, that as I said, if you just the take-home message is that 80% of cases will resolve with proper compliance and encouragement by us with regard to the normal conservative measures, and obviously to consider after a certain time period a differential diagnosis and perhaps refer on if we're not happy with how our treatment is going. That's it.
Excellent.